Good evening. I'm psychiatrist Jay Fawver, live from the Bruce Haynes studio in Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call here in the Fort Wayne area by dialing 969-2720, or if you're calling any place coast to coast, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email question I recently received. It reads, Dear Dr. Fawver, I have started taking an antidepressant and I'm suddenly having trouble sleeping. Is there a correlation? Yeah, I always tell people, if you're having side effects, try to relate and correlate when that side effect started. So if you started taking a medication of any kind, and all of a sudden you started noticing that yourself feeling differently, feeling untoward effects in any way, yeah, it might be related to that medication. And early on, medication side effects can be worse than later. So what we typically will do if somebody's having uncomfortable side effects of any kind from any medication early on, we'll have people take a lower dosage. Some antidepressant medications can give you a worsening of your sleep because they're activating. Sometimes they're affecting chemicals like serotonin. They can give you difficulty going to sleep, nightmares, all sorts of different side effects concerning sleep. And if that's the case, we will typically have people lower the dosage. We might have people take the medication in the morning rather than the evening, but that can be a side effect. Be reassured, usually those kind of side effects involving sleep are not long lasting. Sometimes sleep will just need to normalize over the course of time, but I don't like people to have those uncomfortable kind of side effects. I'd prefer people lower the dosage under your clinician's supervision and try to see if you can write out the early effects of the medication that might be causing you difficulty with insomnia. Thanks for your call. Let's go to our first caller. Hello, Mason. Welcome to Matters of the Mind. Mason, you want to know, how does Lexapro treat major depressive disorder and what are the side effects of Lexapro? Lexapro is also known as escitalopram, Mason. It came out about 20 years ago. And Lexapro is a medication. It's very selective in what it does. It will block the so-called reuptake of serotonin. What does that mean? Well, if you can think about how your serotonin network is working in the brain, serotonin comes spewing out from this inner area of the brain. And from that inner area of the brain, it will go to the outer cortex of the brain. It involves in about 1% of all neurotransmission in the brain itself. So serotonin comes from the raphe nucleus and it gets sprayed up here to the outer cortex. Now, the way that works is if you can think about your serotonin neurons as being like shotguns, and they're firing out little serotonin bullets. When those bullets get fired out, they will stimulate 14 different targets. And these different targets are known by numbers and letters, serotonin 1A, serotonin 1B, and so forth. They have different letters and numbers associated with them, but there's 14 different types of serotonin targets out there. Serotonin will go out and stimulate various targets. And then to preserve serotonin, the brain knows with those shotguns to vacuum back into serotonin, back into the firing neuron. So it's like a shotgun vacuuming back in its little pellets. It's just shot. So it goes back into the neuron to preserve the serotonin. Well, if you will block the reuptake or block the vacuum of the serotonin, more serotonin stays around and bounces around and hits those targets again and again and again. And that's one of the ways that the serotonin reuptake inhibitors, such as Lexapro, will work. So basically, when you think about Lexapro, it's enhancing serotonin in the brain. Now, for many people, that will give them somewhat of a blissful feeling. It often works well for anxiety. There's over a dozen different indications for a serotonin reuptake inhibitor for anxiety. So you'll often find these serotonin medications being very helpful for anxiety. They can decrease crying, they can decrease rumination and brooding, so they can have a calming effect. But 2 out of 3 people who take a medication like Lexapro might not feel well. They feel better, but they might not feel well. So we have to be creative sometimes on what we might add to the Lexapro or another medication we might use alternatively. Its side effects can be, number one, you can feel so emotionally dull. You don't feel happy, you don't feel sad, you just feel kind of blah. That's one of the biggest complaints we hear about the serotonin medication. And key there will be to often decrease the dosage. Secondly, you can have difficulty with restlessness, where you have a hard time sitting still. And then you have the common side effects that are due to serotonin overload, such as headache, nausea, fast heartbeat, diarrhea, shakiness. Those can all occur if you get too much of a dosage. So we're often watching very carefully about the kind of effects you're getting from a medication like Lexapro. Yeah, we want you to feel calmer. We want you to feel less anxious and less ruminative. We want you not to cry as much. But if you're having side effects from the medication, we have many, many other options at this point. Thanks for your call. Let's go to our next caller. Hello, Ted. Welcome to Mayor's the Mind.
Hey, Doc Fawver, how are you?
I'm doing all right, Ted. How are you?
Watch you every week, and I really appreciate everything you have to say.
Oh, thank you so much, Ted.
Here's my question. You know, you often talk about how important it is, how important sleep is. And, you say it's good to, go to bed and to get up at the same time every day. But a couple of weeks ago, you said, but if you had to just do one or the other, you said that it's really important to get up at the same time every day, even if you don't go to bed at the same time every day. Why is that?
You listened very well, Ted. The reason you're doing that is you're trying to get your brain in a circadian rhythm such that you're getting awake every morning at the same time, even though you still might be tired. Now, you might say, well, my goodness, I only had 5 hours of sleep. I couldn't get to bed till 1 a.m. Well, that's okay. You want to try to get up same time every day to try to get your homeostatic rhythm, your circadian rhythm, all these rhythms going on in your brain. You want to get them set at the same time. Now, you might need a 30-minute nap, or maybe a 45-minute nap at the very most, midday to get you through the day. But you want to get your brain into this very set clock where you're getting up at the same time every morning. And people will say that they have a hard time doing that because they like to sleep in on the weekends. There is a phenomenon called sleep debt. It's a real phenomenon. It was controversial 20 years ago, but sleep debt is where you slept 5 hours on Tuesday night, you slept 6 hours on Wednesday night, 7 hours on Thursday night, 3 hours on Friday night. So you're kind of behind in your sleep all week, and then you sleep 12 hours on Saturday or maybe Sunday, and that's okay. So you can kind of catch up, but ideally, in a perfect world, you want to try to get up at the same time every day to get yourself on track. What your brain doesn't really like is where you're getting up some days at 7 a.m. and other days at 10 a.m. and some days not till noon. Think about an adolescent. That's what they will often do. They'll have their circadian rhythm all over the place. Ideally, your brain wants to get in the same routine or the same rhythm where you're getting up at the same time every day, and thereby you will get tired at the same time every night. So in the perfect world, from a sleep hygiene standpoint, you want to get up every morning at, let's say, 7 a.m., and then you'll get tired or sleepy at a certain time in the evening at 9 p.m. or 10 p.m. You want to go to bed when you start getting tired. You do not want to try to fight through that, because it's like trying to catch a bus that's coming by every hour and a half. If you don't catch that bus when you're tired at 10 p.m. or 10:30 p.m. or whatever time that might be, if you don't catch that bus, next thing you know, you're not getting tired till an hour and a half later. So you want to try to take advantage of that time when you're starting to feel tired. You don't want to take a look at your cell phone. You don't want to check your email or start going through social media or looking at YouTube, those type of things, while you're going to bed. Many people will do that out of habit. It's very dangerous to do that because you can stay awake for a much longer period of time, and it's often like missing that bus for trying to get to sleep at that time. Did that answer your question, Ted?
It does. Thanks so much. Is there such a thing as too much sleep for somebody over 70?
If you're over 70, Ted, I encourage people to sleep the best they can. Now, what you don't want to do is sleep 2 hours during the day, because if you do that, that really messes up your sleep at night. But sleep is so important as we get older. I remember 30 years ago, and even 40 years ago, when I was in training, it was thought that older people weren't supposed to sleep so much. That's a fallacy, because older people need to sleep just as much as younger people, if not a little bit more, because it's good for our brains. So us older folks, we need to fire up that front part of our brains, and good quality sleep and lengthy enough sleep is actually good for your memory center. So a risk factor for dementia for us older folks will be if you're not sleeping adequately. So that's why in psychiatry, we look at sleep disturbances like as a psychiatric vital sign. We're always asking about sleep. If you're getting asleep, if you're staying asleep, do you feel refreshed when you get up? Do you feel like you have to take a long nap during the day? And we're always looking, as you might have heard me say many, many times before, we're always looking for this phenomenon called sleep apnea. And as we get older, we're more prone to having sleep apnea. We're not getting adequate airflow to the lungs at night because you're snoring, you're pausing your breathing. That is a big factor for waking up frequently and feeling sleepy during the day. So we're looking at these other type of factors that might be associated with sleep disturbances, Ted.
Thank you so much.
My pleasure, Ted. Thanks for watching.
And Happy New Year. Yeah.
Happy New Year to you too. Take care. Let's go to our next caller. Hello, Ann. Welcome to Matters of the Mind. And you want to know, how do you know if you're suffering from depression or anxiety? I often tell people, Ann, it's often one of the same. And here's what happens, Ann. Many people will start having anxiety where they ruminate about the past. They had doubts. They have misgivings about things that occurred in the past. And they think about the future. They start to worrying about what's going to happen tomorrow and the next day. And they're going over and over these different things, okay? What that often does, Ann, is it causes you to have difficulty with sleep. Just as Ted was mentioning, when you have difficulty with sleep, often you take those worries with you to bed. And when you have insomnia after you have anxiety, that often will lead to depression, because if you don't sleep adequately at nighttime, your front part of your brain does not get adequately recharged. So it's like having a really bad cell phone battery. Have you ever had a bad cell phone battery where you lose charge halfway through the day and you think, oh my goodness, I can't keep the charge on this thing? That's what's happening if you don't get adequate sleep. The front part of your brain, which is the thinking part of your brain, the coping part of your brain, the part of the brain that allows you to make good decisions, that part of the brain doesn't get adequately recharged if you don't sleep well. So anxiety leads to insomnia, not uncommonly. Insomnia leads to difficulty with depression, and it all kind of is a cascade. So when we talk about depression and anxiety, if it's often one of the same. 3 out of 4 people with depressive symptoms will have anxiety symptoms. So 3 out of 4 people with so-called depression, or what we call major depressive disorder, will often have anxiety symptoms as symptoms that go along with that. And the anxiety symptoms will be restlessness, insomnia, ruminative thoughts, doubts, anxiousness, worry. You feel physically uncomfortable. That's not uncommon at all. Thanks for your call. Let's go to our next caller. Hello, Joni. Welcome to Matters of the Mind. Joni, you want to know, is EMDR, also known as eye movement and desensitization reprocessing, successful in treating dissociative amnesia, fugue, or other conditions? EMDR is particularly effective, Joni, for post-traumatic stress disorder. What EMDR is doing, it sounds unusual, but the therapist who's very well trained in EMDR will know that with certain finger movements and eye movements, you can actually fire up the thinking part of the brain. So the rational part of the brain in the front here can be fired up in a good way with certain eye movements. So the eye movements will cause improvement with the front part of the brain. It's been studied the most with post-traumatic stress disorder. If you have dissociative symptoms where you're having difficulty with forgetting what you've been doing for a few seconds or a few minutes, and you kind of go off into another world briefly in stressful situations, that's called dissociation, and it's a coping mechanism people who have chronic traumatic experiences will often find themselves resorting to doing, where they're dissociating and they're kind of going off into their own world temporarily because of stressful situations. So if the dissociative symptoms, the fugue and so forth, are related to post-traumatic stress symptoms, EMDR could certainly be helpful. Thanks for your call. Let's go to our next caller. Hello, Tracy. Welcome to Matters of the Mind. Tracy, you want to know, does talking to yourself mean higher brain functioning? I think, Tracy, some people will simply talk to themselves, not because of a psychiatric disturbance at all. They talk to themselves basically to keep a placemat, a placeholder, so to speak, in their brain. And some people are more visual learners. Some people are more kinetic learners, where they learn better by doing things, and some people are more auditory learners. So if you can talk to yourself, kind of like reading out loud, so to speak, you can actually hear yourself saying things and reminding yourself of different things. Not considered pathological whatsoever. I don't think it's necessarily associated with greater intelligence, so to speak, but it can be something where it allows you to think more clearly about a particular endeavor in which you're pursuing at that time. So for some people, they need the visual, some people need kinesthetic, where they're moving around, some people need auditory stimulation to try to learn things. For some people who talk to themselves as they're trying to think through a problem, that's not considered a problem at all, but I don't think it's necessarily associated with increased intelligence. It's just saying that you're probably an auditory learner if you do that more commonly. Thanks for your call. Let's go to our next caller. Hello, Zane. Welcome to Matters of the Mind. Zane, you want to know is what is schizoaffective bipolar disorder, and can it be treated with Cobenfy? Schizoaffective bipolar disorder, basically, Zane, is where you have day-to-day symptoms of schizophrenia that have undoubtedly been there since you were an adolescent, maybe an early adult, but you'll have difficulty with hearing voices when other people are not there. You might have fixed false beliefs, which are known as delusions. You have difficulty with social anxiety. You often will have difficulty perceiving social cues from other people. You might have trouble with a thought processing ability, and when you speak, you're going from one topic to another. It might be difficult to follow. Those symptoms are there more often than not without treatment. That's schizophrenia. Affective bipolar disorder aspect of that is where periodically you'll have a few days, if not a week or so, of being high or low. So being high means you're on top of the schizophrenia symptoms, you're also having decreased need for sleep. Your thoughts are racing really fast. You're doing things extremely impulsively. That's the manic episodes of schizoaffective disorder. Then you might have the depressive episodes where you're more socially withdrawn, you have less motivation, you don't enjoy things, you have low energy. So you can have these ups and downs with the affective bipolar disorder. Schizoaffective bipolar disorder is where you have schizophrenia day by day, and then periodically, occasionally, you'll have changes in the mood where you're up or down. Can that be treated with Cobenfy? Cobenfy was approved by the Food and Drug Administration over a year ago for the treatment of schizophrenia. Cobenfy is xanomeline and trospium, two medications in one. So xanomeline is a medication that will specifically address a stimulation on acetylcholine. So by stimulating acetylcholine, downstream, it turns off the faucet on dopamine. What we've been using for the past 60 years as antipsychotic medications will be medications that block dopamine predominantly. And if you block dopamine, it's like having a water hose that's going full blast and you're trying to block the effects of it on the other end of the water hose to try to block all this excessive flow coming out. Well, with Cobenfy, you're now actually going to the spigot and you're turning down the volume of the water flow itself. So if you think of the water flow as being like dopamine transmission, that's what that's doing. So theoretically, you bet Cobenfy could indeed be used for schizoaffective disorder, having the difficulty of schizophrenia there by day, in addition to the possibility of ups and downs. Cobenfy is not yet approved for manic depressive disorder or bipolar disorder itself, but it certainly could be helpful for the schizophrenia symptoms. And sometimes these medications that are useful for decreasing dopamine transmission somehow are also good for bipolar symptoms as well. So chances are it could be helpful for schizoaffective disorder. Thanks for your call. Let's go to our next caller. Hello, Craig. Welcome to Matters of the Mind. Craig, you want to know, how do you know if someone's prone to violence with schizophrenia, and will medication changes make a difference? Right off the bat, Craig, I'd wonder if somebody has schizophrenia, if they're prone to violence, do they have a family history of schizophrenia? That's highly predictive. If you have an identical twin, for instance, same genetics as you, and that identical twin as you has schizophrenia, you have a 50-50 chance of having schizophrenia. So schizophrenia is about 50% genetic. If you have a mother or father with schizophrenia, you have about a 12% chance of having schizophrenia. So we're always going to be looking for any family background with schizophrenia when we think about somebody's having schizophrenia. Now, if somebody has an extensive history for years, if not decades, of drug abuse, they've been using amphetamines, they've been using hallucinogenics, they've been using cannabis, all these different things, you might have very similar symptoms as somebody with schizophrenia, but you don't have the genetics that are there. So when I hear about somebody using extensive drugs over the course of time, those drugs themselves, especially in the event of a relapse, can cause, I think, more violence than you typically see with schizophrenia that was genetically brought on, so to speak. So there's different types of phenomena that can occur. If somebody has a family history of schizophrenia, I think they're less likely to become violent. But if somebody has psychosis where they're losing track of reality, they're getting aggressive and irritable, related to the history of drug abuse, the drug abuse itself might have damaged the brain for that person that would make them more prone to violence. Now, with any of these people, whether they be with schizophrenia or with anybody with a history of drug abuse and drug-induced psychosis, they need to be carefully watched as they're changing from one medication to another. Why? Because as you're changing from one medication to another, as one medication is getting tapered off, the tapering of the previous medication sometimes will cause side effects such as irritability and restlessness. We call it akathisia, but that could be a side effect of coming off the previous medication. While starting the new medication, it might not have enough time to kick in yet. So it's a very sensitive time when somebody's coming off a medication, starting a new medication. They need to be followed very carefully because they can have some irritability and aggression during that time because the previous medication is getting out. The new medication is not quite effective at that point. Thanks for your call. Let's go to our next caller. Hello, Denise. Welcome to Matters of the Mind. Denise, you want to know why are some people disorganized? Is it ADHD? What causes people to clutter and have difficulty with focus? ADHD can be a phenomenon that leads to people having disorganization and being cluttered and unfocused, and it's something that will typically occur as a child, at an onset. So if somebody has ADHD, they've had those symptoms going back to childhood or early adolescence, and more days than not, those problems are there. However, the problems involving attention deficit hyperactivity will be worsened if you're challenged with a new project. In other words, you might be doing fine for a long time if you've had the same routine projects, and all of a sudden you have a new challenge ahead of you. That can sometimes cause you to have difficulty with being able to cope with distractibility and inattentiveness because of the new challenges. So even as an adult, you'll notice that ADHD symptoms might be in pretty good control, but if you're what we call not having enough cerebral bandwidth to be able to tolerate certain situations, the ADHD symptoms might be much worse for you. So if you're having difficulty with focus and having things more cluttered, that can be a symptom of ADHD, can be habit. I think it all goes back to looking at a person's personal history. I'm more concerned about somebody who was perfectly organized for years and years, and here they are, 45 years of age, and they're all of a sudden they can't keep track of things. They're having trouble with focus and concentration. So women, particularly in that age group, can be going through some perimenopausal symptoms, because if you have difficulty with perimenopausal symptoms, your estrogen's going down, as it will in the perimenopausal time. When estrogen goes down, you'll have difficulty getting your thoughts together. And many women, as they go through perimenopause, and not at menopause yet, but as they go through perimenopause, estrogen's going down, this little hippocampus area in the brain isn't able to function so well. That's the library center of the brain. And you'll be more scattered and more unfocused during that time. That's not ADHD, that's more perimenopause, and bioidentical hormones can sometimes address some of that. Women, after they deliver a baby, not uncommonly will have a crash of their thyroid, because when you deliver a baby, you can have what's called thyroid toxicity, and when you have that occur, you could have decrease in thyroid functioning. That will make you feel really foggy. I mentioned earlier sleep apnea. If you have difficulty with sleep apnea, sometimes you'll have a lot of trouble with concentration and thinking then. So as we look at somebody's symptoms of being unfocused, they're cluttered, I want to know how long those symptoms have been going on, and could there be any more recent medical issue that has been exacerbating those particular symptoms. Thanks for your call. Let's go to our next email question. Our next email reads, Dear Dr. Fawver, I feel like I get overwhelmed easily, which leads me to be unable to manage my emotions. Are there some coping strategies that could help? Getting overwhelmed easily, we call it resilience in psychiatry, and I'd want to know, okay, how long has it been going on? Is it related to being around other people? I'd want to know the causes for feeling overwhelmed. In a new situation like a new job, there are so many different reasons why somebody could be getting more overwhelmed. We all have a certain degree, going back to the whole concept of bandwidth, but we have a certain degree of bandwidth that we can tolerate certain situations based on our life experiences, our ability to cope with those experiences. If you go back to the changes occurring in your life, are you getting too many changes occurring at one time? We should be able to adapt to our day-to-day changes that we're enduring. However, if you are having trouble with feeling overwhelmed, sometimes it can be somewhat paralyzing for the brain and you can kind of shut down. That's where you feel overwhelmed, and that's what we'd want to address. So I want to know the reasons and the particular situations where that might be a problem. Thanks for your call. Let's go to our last caller. Hello, Hannah. Welcome to Matters of the Mind. Hannah, you want to know about my thoughts on marijuana being reclassified as a Schedule III drug. You know, as a Schedule III drug, it means it does have some medical validity, and I think marijuana does have some medical validity, definitely with certain types of seizures, maybe with certain types of pain. I like the fact that it's no longer a Schedule I. Schedule I means it has no medical use at all. I think marijuana does have some medical use. So if it's Schedule III, it allows us to be able to study it, good or bad. I've said all along, I'd love for marijuana to be studied like any other medication that comes for FDA approval, looking at side effects, long-term effects, toxicities, everything, as well as how it works. So I like the idea of it being a Schedule III drug because it puts it on the table, allows us to study it very extensively for medicinal purposes. Hannah, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions that I can answer on the air concerning mental health issues, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. I'm psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS Fort Wayne. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronHealth.com.